Good morning, ladies and gentlemen. My name is Pavel Krsek, and I am really honored to be invited for this first international EDGAR HOUSEPIAN symposium in Armenia. My role is to speak about video-EEG monitoring, and especially in the field of epilepsy surgery. If I can recommend one paper perfectly covering this field, I would definitely recommend this position paper of International League Against Epilepsy and International Federation of Clinical Neurophysiology. It's pretty comprehensive paper covering actually all important aspects in this field. So let's go for individual aspects. Video-EEG is probably most commonly used in differentiating between epileptic and non-epileptic events. In meta-analysis looks very effective. The useful information is obtained in vast majority of patients, and in a significant proportion of patients, the initial diagnosis based on clinical history and first evaluation of patients is changed. There are some particular groups of patients where video-EEG monitoring is useful, such as differentiating frontal lobe seizures from generalized seizures and non-epileptic attacks. So there is a clear recommendation of a panel of experts that video-EEG should be used to differentiate between epileptic and non-epileptic attacks when seizures remain uncontrolled despite appropriate treatment. It maybe looks it's not directly related to epilepsy surgery, but it's not, because the definite diagnosis of epilepsy is actually the starting point of evaluation of patients before planned epilepsy surgery. So please look at this video from our epilepsy monitoring unit. The video of a young girl coming with dozens of these per day. And we have seen such asymmetric tonic posturing with maybe some doubtful features such as immediate contact and no problem after the attack. We can't be completely sure. We have seen many of these seizures. Try to conclude for yourself. Second event, a little bit different. Now we see more pronounced these strange features. So what would be your diagnosis? The final diagnosis were psychogenic non-epileptic seizures. The girl was treated with no effect by a combination of anti-seizure medication without effect because psychological evaluation revealed a dissociative disorder, which could be treated in her case successfully by psychotherapy and psychiatric medication in her mother. So sometimes dissociative disorder could occur even in younger kids, and we must be careful in differential diagnosis. Let's see another case. Again, the girl, 13 years old. We see strange movements appearing during the day from sleep. Many colleagues could be impressed. It's so strange. This must be psychogenic. We see the girl has no disruption of consciousness, strange movements, strange behavior, strange face. Now taking teddy bear, looking around, pelvic movements. So again, what differential diagnosis? in her, we concluded it's typical hyperkinetic seizure. Our initial idea was it could be from frontal lobe, but in this girl, the seizure onsets were mapped to posterior insular region. We mapped her by stereo-EEG. It was in good correlation with PET hypometabolism, and the girl was successfully treated by epilepsy surgery. So hyperkinetic seizures, on the other hand, can be misinterpreted as psychogenic non-epileptic seizures. So role of video-EEG in differentiating epilepsy from non-epileptic events. Another major field is a correct classification of seizures, epileptic seizures, and specifying epileptic syndrome. Again, the meta-analysis, including prospective study, clearly showed video-EEG is highly effective in this field, possible to clarify epilepsy syndrome in vast majority of epilepsy patients, and again, with a high capacity to change initial differential diagnosis and classification of both seizure types and epileptic syndromes, for example, from focal to generalized epilepsy or vice versa. Some subgroups of patients, such as patients with staring, some jerking, abnormal eye movements, and also sleep-related events are particularly indicated for this specification. So conclusion of panel of experts is video-EEG is a standard to help classify patients with epilepsy. Another example, this boy came with drug-resistant epilepsy to our epilepsy monitoring unit, and we considered epilepsy surgery because of these lateralized features. Look at eyes and look at chin. There are some clonic jerks. And first, we have seen clonic turning of the head with no movement of eyes. Look at icto-EEG. It's pretty generalized, 3 Hertz. So we finally concluded it's actually generalized genetic epilepsy with myoclonic absence seizures with transient focal features which were confusing and even led to consideration of epilepsy surgery. These focal features could appear in genetic epilepsies, but they are most frequently transient. For comparing, let's see this girl, and especially her eyes. It's perfectly intact. Now telling father there is a seizure. You see forced tonic deviation of the eyes to the left. She's able to respond. Father is testing her. The smile is not completely related to this particular type of seizure. So what will be our diagnosis? It was sort of a typical seizure from the frontal eye field of the right hemisphere. And on sophisticated neuroimaging co-registration MRI with FDG PET, we found bottom of sulcus type 2 cortical dysplasia. So this girl is perfect candidate of epilepsy surgery. Also EEG with a focal rhythmic activity from the right premotor area was in concordance with this diagnosis. So differential diagnosis specifying type of epilepsy syndrome and seizure type is crucial for consideration of epilepsy surgery. Another important field is quantifying epileptic seizures. It's well known that the reports from patients are not always reliable. Fewer than half of patients correctly document their seizure frequency, and there is a significant proportion of patients who are completely unaware of their seizures. Those are these patients, especially patients with temporal lobe epilepsy, cognitive decline, obviously, and transient epileptic amnesia. The meta-analysis and position paper concluded that overall evidence for utility of video-EEG to quantify seizures is a bit low, but there is, I think, no doubt that video-EEG provides significant help in quantification of seizures, especially in specific situations, such as this one. So she's a girl with diagnosis of focal epilepsy, frontal lobe epilepsy, and we see her sleep during a breeze. See again eyes. We have seen one second of eyes opening, another situation, so against opening, and you have seen this strange movement of the left hand during the sleep. The patient was completely unaware of these events. We have seen dozens of these events per night, and we have seen there were not normal awakening, definitely not. They were related to this prominent epileptiform rhythmic pattern, and we found in this girl MR negative but PET positive cortical dysplasia in the gyrus rectus, so frontal-basal area of the right hemisphere. We proved this diagnosis by stereo-EEG, and the girl was successfully treated by surgery. Both the patient and her family were completely unaware of the number of these subtle seizures, or maybe in the literature we can find the term minor motor events. They are especially common in patients with photocortical dysplasia and tuberous sclerosis, at least in my practice. So video-EEG in surgical management, of course, is a crucial part of evaluation of patients before epilepsy surgery. It's a standard technique to localize the seizure onset zone. It's a predictor of outcome. If we see a localized scalp EEG pattern at video-EEG, it predicts favorable outcome after resective epilepsy surgery, but we must be aware of limitations. Actually, scalp video-EEG has a moderate sensitivity and relatively low specificity for identification of the epileptogenic zone. So we can't never rely on scalp video-EEG. We must correlate this finding with neuroimaging, of course, with seizure semiology, with the clinical picture of patient. If necessary, we must indicate the intracranial EEG study in selected patients. Value of video-EEG is reported to be higher in localization of epileptogenic zone in patients with temporal lobe epilepsy comparing to patients with extratemporal lobe epilepsy. But in my view, it relies mostly on adult patients. In pediatric practice, my experience is video-EEG is the same, has the same value in both these groups. In 2004, interesting paper of Jacquard and colleagues, Pediatric Epilepsy Surgery Task Force published a position paper on the value of individual diagnostic tests in pediatric epilepsy surgery, and concluded that video-EEG is mandatory or highly recommended in all types of pediatric epilepsy considered for epilepsy surgery, with the exception of patients with hypothalamic hamartoma. So this is also the conclusion of the panel of experts. Really a few words regarding technical aspects. There are some very, very obvious statements. It's really not possible to record only long-term EEG. It must be accompanied by synchronized video. One camera is a minimum. More cameras seeing the patient from different angles and also with a different zoom could be also valuable. It's necessary to record ECG to correctly interpret seizures. There is a minimum sample rate, and if you have minimum sample rate, you need sufficient capacity of storage service. It's obvious. What's more important, the current recommendation of International Federation of Clinical Neurophysiology clearly recommends 19 electrodes is not enough for video-EEG, long-term video-EEG monitoring in the setting of epilepsy surgery evaluation, because you never cover well temporal and also occipital basal area. So you need this lower electrodes, F9, D9, P9, and the opposite range of electrode, and in some patients even more dense EEG arrays are valuable because it can provide electrical source localization of epileptogenic zone. If I am correct, sphenoidal electrodes are diminishing from the standard video-EEG procedures, and also in our center we have abandoned them. Again, a few words regarding practice at epilepsy monitoring unit. We need some standardized protocols. First, the standardized protocol for testing patients during seizures. I simply recommend this fantastic paper on Benitsky and colleagues, perfectly summarizing this field, and it's really necessary to train your personnel. Second, especially in patients with focal epilepsy undergoing pre-surgical evaluation, it's really necessary to have standardized protocols for seizure emergencies and the use of rescue medication, and also the approach in the case of status epilepticus is really critical in these patients. And finally, obviously, you need standardized protocols of reporting seizures, where we recommend to follow updated terminology of interictal and ictal EEG abnormality and seizures, and currently used classification systems. Regarding staffing, it's sometimes tough because it has financial problems. Not all centers are able to follow the recommendation of optimally have in-house 24 hours, 7 days per week service of EEG technologies. Of course, what's optimal for the quality of recordings, but I can tell you, even in my center, it's not for the whole week. We have 3 days with the 24-hour service of EEG technologies. Otherwise, you simply need to train nurses, which can test patients also during the seizure, recognize significant EEG artifacts, maybe to replace few electrodes or simply contact on-call EEG technologies. I hope this is feasible approach. There are some discussions of minimum nurse to patient ratio. The recommendation of British society is not to exceed the ratio of 4 patients to 1 nurse in adults and 2 patients to 1 nurse in children. Let's go to children. Regarding technical aspects, we see maybe the major problems at the beginning, so the placing of electrodes, because children are not always cooperating well. My experience is that there is a crucial role of EEG technologist who is experienced, and if you have experienced pediatric nurse and pediatric technologists, you only rarely need sedation of patients for placing electrodes. I have heard many times that 25 electrodes is too much in infants or young kids. In my view, it's not true, definitely not. We use 25 electrodes for video-EEG monitoring in all age groups, maybe except for premature neonates. Staffing, I think it can be, it must be a rule. The child is always admitted together with patients, what helps a lot to the personnel, and I explained the critical role of personal experience with children. And if you see this photo, you can understand how important is this last very basic advice. Try do everything to prevent boring of patients, simply to allow normal child life activities, and you will have not such problems with technical artifacts in your video-EEG. Okay, but more important than these technical aspects is a difference in children in interpreting seizure semiology. Please look at this 22-month-old girl with the early seizure onset. It was a COVID era, and you have seen first atonic seizure. Second one, maybe you could recognize also a mild movement of shoulders. Third, so actually it's a series of spasms, and it looks pretty generalized, non-lateralized seizure type. Also, the EDGAR, this typical fast activity followed by slow wave, it's typical for spasm. It's lateralized to the left. On the left, there is prominent widespread slowing. But when we see MRI, we can clearly see localized dysplastic lesion in the temporal pole on the hemisphere, hippocampus and amygdala. So it's a nicely resectable lesion. And truly, this girl became seizure-free after removal of the dysplasia. Strange seizure semiology, no doubt, but we must be aware this generalized type of seizure semiology and even generalized type of EEG patterns is common in children with early seizure onset. So don't exclude, please, these patients, these children from epilepsy surgery consideration. For comparing the same age of patient, 20 months old, but later seizure onset. Now we see the change in behavior. The boy became scared, threatened, crying. Mother is recognizing the seizure. There is monotonic movement of the head to the right shoulder, and the patient is not responding. there are some vegetative signs which are not perfectly visible from the video. So pretty different seizure semiology, very different. Surprisingly, if you look at MRI, we see something very, very similar to the previous girl with completely different seizure semiology. Although the rhythmic pattern on scalp EEG is very different. Here is nicely localized over the left temporal area. So what's the different? The different is in the age of seizure onset. So older child at seizure onset has simply more mature seizure semiology. And we see this fact in many patients. So the developmental aspects in interpreting seizure semiology and EEG patterns is crucial for epilepsy surgery consideration in children. The last slide regarding safety issues. Of course, Video-EEG itself is not a risky procedure, but something what happened around can be risky. So there are two fields to discuss. First, activation procedures. We simply want to see seizures, so we should provoke that. So first, activation procedures. There is a recommendation of hyperventilation and maybe weaker evidence of sleep deprivation. Both these procedures could be useful in increasing spike rate and also activating epileptic seizures. Not in all patients, definitely not, but in subgroups, and we can try. I have not so much experience in activation procedure in diagnosis of psychogenic seizures. I will skip this, but I would simply warn that the publications are also these patients with psychogenic seizures are prone to adverse events, most frequently false. So be careful. And the major issue, obviously, drug reduction. So first, it's routine procedure to increase the likelihood of seizure capture. It's used in all Video-EEG monitoring units dealing with patients in pre-surgical evaluation. Unfortunately, it's a pity, but there are no standardized protocols for reduction of anti-seizure medication. When we have patients with no history of status epilepticus or frequent daily seizures, that is, of course, useless, even fast tapering can be considered. And in my practice, when you have trained personnel and standardized protocol, how to approach the patient with clustering of seizure, it's actually a safe procedure. But there are some reports that rapid withdrawal may potentially obscure localizing info at seizure onset in the EEG. My practice, my experience is it's not such a common problem. But back to the main issue, the main issue is trained personnel who is able to respond to the situation triggered by seizure, by drug reduction. So these were some ideas on Video-EEG monitoring and its role in epilepsy surgery. And the last slide, I really want cordially invite you next June to Prague, where is 15th Congress of European Pediatric Neurology Society. It will be a big congress, including the dedicated epilepsy pre-congress symposium, and we will be happy to see you there.